Thank you so much for another fantastic session of talks. And as ever, lots of questions. So straight into it we shall go. And I'm going to kick off with one for Stephanie, please. How does one manage the physical and psychological symptoms of EDS and HSD and comorbid conditions when their primary doctor does not understand and they're on a very, very long waiting list for specialist help?
I think that's an amazing question. Thank you so much for bringing this up. It's so vital that we have a really good healthcare team that both understands and supports the symptoms that are most concerning to you specifically. It's really difficult, I think, to find a good primary care provider who can spend the time with a patient. Most appointments, unfortunately, are limited to like 15-minute or 30-minute segments, and it's really difficult to get out all of your concerns and address such a complex concern in that amount of time. I think that sometimes finding primary care doctors who unfortunately are outside of the insurance perspective of things, at least in the United States, can be more helpful because you can get a longer appointment, or just being straight up and talking with your PCP about your concerns that you may need a longer appointment time. And then also, you know, looking for other specialist help in the meantime of being on the waiting period.
Thank you so much.
Lara, could I just jump in and ask Stephanie to comment on the nurse's role? Across many areas of complex disease, there are specialist nurses. You have an amazing role as a kind of a specialist nurse in EDS and HSD. What's your view on the development of nursing in this specialty as an incredible resource that we just don't have enough of at the moment?
Thank you so much, Dr. Hakim. I really appreciate that. Being a nurse specializing in EDS is a huge, vital part of everything that I want to do. And I do wish that there were a lot more nurses who had this special interest in, working with EDS patients and the like. So my role, I primarily find, is to reinforce, what the care plan is for the patient, and also to help patients navigate this complex healthcare system, because dealing with EDS and its comorbid conditions is very overwhelming. And so for a patient to be feeling so unwell, coping day to day with their symptoms, and then also have the added burden of just navigating through everything that, this challenging field presents, I think a nurse can really have the time and the ability to communicate with a patient on a regular basis if needed to help the patient in that way.
Thank you. Dr. Chopra, what are some non-addictive, non-harmful medications for pain relief that people can take safely for long periods of time? And can you comment on amitriptyline?
Okay, so taking the first part of the question was really treatment of pain depends on what's causing the pain. And, if you have a dislocated joint, or if you have mast cell activation syndrome, treating those is what's going to help. You can take all the medicines and pain medicines in the world, it's not going to make a difference. For example, mast cell activation syndrome is an extremely painful condition. The more medicines you take, more likely you're going to make it worse. NSAIDs make it worse, opioids make it worse. Same thing with a dislocated joint or a sublux joint. The muscle spasms because of the subluxation. Unless you stabilize the joint, nothing in this world will work, unfortunately. Having said that, there are some medicines which actually fall within the neuropathic pain conditions that I think are helpful. Amitriptyline being one of them. It belongs to a class of tricyclic antidepressants. So amitriptyline, nortriptyline. Doxepin is a better choice because doxepin also has mast cell activation properties. It helps MCAS at the same time. So that's another choice to do. Amitriptyline, nortriptyline, the side effects, unfortunately, are a lot of lethargy and bladder issues. My drug of choice for neuropathic pain and some of the more musculoskeletal pains is a medicine I call it LDN, or low dose naltrexone. It's a bit out of the box, but there's much more literature now out there on LDN, and I would certainly give that a try. It's a non-narcotic drug. It's unlike other pain medicines, this is a disease-modifying agent, and I think it's worth looking at that. I'm not a huge fan of opioids, but a small dose of opioid, if it helps you get through an acute phase, it's great, because the problem with chronic opioids is that it can make your GI issues worse. It can make your mast cell worse. Same thing with NSAIDs like Motrin, ibuprofen, and all those. Again, they can make your GI issues worse, make your mast cell worse. But if it's an emergency, if it's an acute thing, sure, go ahead and take it. There's absolutely no harm in doing that. But for the long term, I'm okay with doxepin, amitriptyline, nortriptyline, and LD and low dose naltrexone. Over to you.
Thank you. Thank you. Dr. Pocinki, could we scroll up a little bit? Thank you very much. Is there a way to test for cortisol issues if your standard blood tests seem to be normal?
Unfortunately not, because cortisol is made in spurts. It's not made continuously. And so, as I mentioned, one of the features, one of the main principles or properties of these syndromes is the tendency to overreact to minor stresses. And so most of the time when your body overreacts to a sudden unexpected noise and your heart starts pounding, you sort of recognize the symptoms of that you've just sort of gotten an excessive adrenaline stress response. But in that same situation, you're almost certainly making an excessive amount of cortisol. And so unless you can somehow measure your cortisol in the middle of such an episode, you're really not going to see it. In fact, I'm glad you asked the question, because in fact, we see just the opposite, that when your body has made an excessive cortisol stress response, it will then suppress cortisol production for a while thereafter. So it's more likely to draw your blood and check for a cortisol level. It may actually be low normal or even low in some of these patients who, when you look at them, you can see from the weight gain in their face, from the weight gain in their abdomen, some of them even have the classic hump across their upper back, that they're making too much cortisol, and yet randomly drawn serum cortisol levels are low. One of the ways I've sort of confirmed this clinical impression is with a number of patients who are actually referred to me with the instruction, please ask Dr. Pocinki to check your cortisol and make sure you don't have adrenal insufficiency. And I can look at this person and say, you clearly don't have adrenal insufficiency. And what we've done is just repeated at random times serum cortisol levels. In a number of cases, we've seen 4, 5, 6 levels that were low, and then finally managed to catch one during one of these surges. One woman had normal morning cortisol levels between about 3 and 18. One morning it was 5, the next morning it was 9, and the next morning it was 29. Exactly the same time, there was nothing obviously different going on. Classic teaching is to collect urine for 24 hours for cortisol to see if you're overproducing cortisol. But in this situation, the highs and the lows will offset, and your 24-hour production normally will not be elevated. So again, this is a syndrome that classically trained endocrinologists don't recognize, but it's something that I see clinically, and every time I hear about the latest new monoclonal antibody to block some kind of interleukin or cytokine, I wish we had a drug that blocked the effects of cortisol. Just would be very helpful. But at this point, the most helpful thing about understanding this sort of paradigm is reassuring some people who are just really frustrated with their weight gain, and say, okay, I believe you that you're not overeating. I know you're not drinking too much alcohol. I know you're not going through the fast food drive-through. This is cortisol. This is your body overreacting to stress.
Thank you. Very interesting. Question for Stephanie. I think we're getting some feedback. I'm not sure it's from in here. Okay, seems to have gone. Okay, question for Stephanie. Do you have any tips to cope with hospital admissions or other situations when you don't have access to regular self-management strategies?
Absolutely. I do think that this probably varies between countries and between different types of hospitals. As you know, here there are, regular community hospitals, and then there are specialty hospitals. So there is a large difference between the two in having access to specialists that will understand your needs. I do know that there are some great printable resources, especially on the EDS Society website, that can help educate your providers if you come across like an ER doctor or somebody like that who is very unfamiliar with EDS. And it does happen quite frequently. Not because, that they don't want to know about it, but because they don't come across it very often. And so instead of, being so anxious that they don't know what your needs will be, you can have an advocate with you. You can, print resources, and you can educate them and really try and work together in managing your care. EDS and hospital admissions is something that's very, very difficult because it takes so much out of you in regards to pain and fatigue. Waiting in the ER, driving there, just being in a hospital is absolutely very exhausting. There's something that, expecting mothers do when they are knowing that they're going to be needing to go to the hospital to give birth, is packing a to-go bag. And sometimes that can be really helpful, is just knowing that you'll have a bag with everything that you need with you in case you do need to go to the hospital. And so I think that, just saving yourself the energy where you can, and always being prepared with information, education, advocacy, and, things like a list of medications, a list of diagnoses, because oftentimes patients are taking a lot of medication, have a lot of diagnoses and a big surgical history. Having that all typed out and ready to go with you can save you a lot of exhaustion explaining it to other medical professionals when you're already not feeling well and inpatient.
Thank you.
Laura, could I just pass a couple of comments, because I have a lot of patients who have need of emergency access. I think one really important thing for all of us to remember is that ERs and accident and emergencies primarily are there to make sure that somebody doesn't have a life-threatening disorder that needs immediate attention. Now, I know that the vast majority of the things that take my patients to the emergency room are extremely acute and very worrying symptoms, but they're not life-threatening. So I think it's important for us to appreciate what ER and A&E are actually there for primarily, and also just to bear in mind that they have to have a wealth of knowledge around a variety of conditions. And for most chronic long-term conditions with acute on chronic pathology, they won't have that experience. They're looking to make sure that your blood pressure is okay, that your heart is ticking, that you're breathing. Thereafter, they need to get you back to your chronic care team to manage the acute problem, because they can't manage it from ER or A&E. One of the things that I've learned to do with my patients who are having to attend A&E on a regular basis is to build a care pathway for them, which includes the paramedics at home all the way through to the response of the emergency team in the emergency room, and the relationship with the chronic team network, so that everybody's much, much more aware. So if you're a regular attender at an emergency room, it's good to try and get your community clinicians to build a pathway of care for you with the paramedics and the ER room.
Thank you. It's very helpful. Dr. Chopra, so the famous 1 to 10 pain scale used in medical settings, which I think frustrate many people with chronic pain. How do you manage them when the numbers seem arbitrary, when you consider living with daily chronic pain? This person says they feel like they're doing calculus every time they're asked to rate their pain.
So it's called the NRS scale, the numerical rating scale. Personally, I think it's garbage. Unfortunately, when it was established somewhere in 2000, and no one really follows it. What happened was the World Health Organization wanted some sort of a vital sign number, and they called it the fifth, or I think it's the fourth vital sign. But unfortunately, physicians have to document an NRS number, and it really doesn't make a difference. You can say I have 10 or 10 pain, or you have 2 or 10 pain. They don't care. No one cares. But it's really important at the same time to tell them your most important problem. And so, for example, if you're having pain in your shoulder joint and it's because of a subluxation, you can say, listen, my pain is extremely severe in my right shoulder. It's 10 or 10, but my shoulder seems to be out of place. And that's what makes a difference. But the scale system is useless. There have been many, many scales that have come out, and in the big picture, they don't really work at all. But because of insurance requirements, legal requirements, they have to document it, unfortunately.
Thank you. Dr. Pocinki, where did that question go? There it is. How much deep sleep and REM sleep should we get, and what is too much or too little?
Very roughly, 15 to 20% of your night should be spent in each in REM and in deep sleep, and the rest of the night in shallow sleep. I don't have any familiarity with syndromes where people get too much of either one of those. So I don't think there's a physiologic problem with getting too much. There are some medications that tend to make you spend more time in REM. There are some medications that can delay the onset of REM. But I think getting enough is the goal without worrying about getting too much.
Thank you. Question for Stephanie. What specific type of magnesium supplements do you recommend, citrate, oxide, chloride, for example, for muscle pain?
I don't find that there's any one that's better than the others. However, there have been studies showing that specifically for muscle pain and spasms, that magnesium oxide and chelated magnesium are the most easily absorbed. So therefore, probably the most effective.
Thank you. I think people also need to consider the GI reactions that people can have with the different forms as well. So I know personally I've been experimenting with the different types to balance out the benefits for the muscles, and then to try and then deal with GI issues that can arise. So I think people need to try for themselves which works and then balance the benefits. That's been my personal experience.
Actually, the best way to get magnesium without the GI issues is to use topical magnesium, and it comes in two forms. You can buy magnesium oil or spray lotions. You can buy them. Apparently, they come from a lake in Netherlands. But anyway, you can buy that on Amazon. It's easily available. And the other way to get it is with Epsom salt. Epsom salt has a lot of magnesium. 2 large cups of Epsom salt in a bathtub, soak yourself in it for 15 minutes. You've got your dose of magnesium for the day without the GI effects.
Yeah, absolutely. Thank you. And staying with you, Dr. Chopra, body awareness is important for managing pain, but it's difficult when you're in pain. How do you recommend negotiating this?
Lara, could you repeat that again?
Yes. Can we get that question back? Sorry. I think it was body awareness is important when managing pain, but it's difficult when you're in pain. So proprioception and thinking about considering the body in its space. So how do you negotiate that when you're in so much pain, but you need to manage the body awareness?
Negotiate with yourself, or well, I'm not sure whether they meant negotiate with their providers.
No, with your own body. So trying
okay.
to manage pain with the awareness of your own body, but knowing that pain makes that harder. How do you negotiate the two things?
So it's not, one of the things to remember is that you're not treating pain, you're treating function. A person can have 9 or 10 pain in their knee and still be functional, and another person can have 2 or 10 pain and be non-functional. And so the question is, you have to look at about being functional. In terms of, I wasn't quite clear about the negotiating part, but people with EDS have 2 kinds of pain. One is the chronic regular pain that they have on a day-to-day basis, and it's on multiple places. For that, you'll have to look at some of the other modalities. How do you manage to, fix your proprioception, help your muscles be more stronger, and the many things that we talked about. But the other one is to look out for what is called an acute on chronic pain, which is an acute flare-up of your chronic pain. And the best way to do that is to look for triggers that can cause your pain to become acute. So for example, let's say I have pain in my right leg, and anytime I walk, let's say I have pain in my right leg because I have a bad ankle, a loose ankle. So, the way to negotiate with yourself on that is to make sure that you're always taking care of that ankle. You're wearing your, shoes, your high top shoes, you're wearing your brace, keeping your joint stable, and avoiding getting into the realm of acute on chronic pain. Prevention is the key over here, for at least for the acute and chronic pain. But as far as chronic pain itself is concerned, you'll have to look at all the other modalities that we talked about.
Thank you. Dr. Pocinki, is there anything that we can do to help improve energy levels?
I think hopefully I covered some of that in my talk. I think that the answer to that question usually is the graphic I put up of the swimming pool, that improving energy levels, in order to improve your energy level, you need to do the things that give you more energy, which are usually the major thing there is getting a more restful night's sleep. Correcting nutrient deficiencies will help. There are some other smaller things that will sort of add energy to the pool. But besides your sleep, the major thing is to look at all the things that are taking energy away, recognizing that people tend to undertreat their pain, and pain drains a lot of energy. People do tend to push through fatigue because they're trying to do more than they're really able to do. So trying to, recognizing, as I've made the point, that daily activities are more tiring, take more energy. So conserving energy on the one hand, will leave you more, and then addressing the things that are taking up energy. And then the big thing is trying to improve the quality of sleep.
Thank you. And the last question for Stephanie, and we want to ask this to you in a patient with a patient hat on. In your experience as a patient, what helped you the most and still helps you the most on the daily?
Wow, I think that's a great question. And I really like Dr. Chopra's, comparison of everything is 10%, physical therapy is 10%, medications 10%, pacing yourself, sleep, everything adds a little bit to the picture of overall just vitality and being able to cope and managing your symptoms well. In my personal experience, I can't say that any one thing has helped more than anything else. I think it has been a trial of trying to find different things that have helped me just a little bit to get to the point where I am now, where I can function. My function is excellent at this time. I'm doing really, really well, thankfully. And that has been because I haven't given up on any treatment that has given me that 10%. And so if anything has just provided me a little tiny speck of relief, I have clung on to that. And then I have found something else that gives me a little bit, and it just adds up over time. So the combination of that, and just like Dr. Pocinki was saying, sleep is so important. So really just balancing out managing my pain and then managing my fatigue, I felt like that has created the optimal triangle of wellness for me personally. For everybody else, your symptoms may be different than mine, your severity may be different than mine. So all I can say, though, is don't give up on treatments that give you 10% relief. Keep finding more and add it on, and it'll eventually stack and build up on top of one another. And eventually you will find something, a combination that is very personalized, not something cookie cutter, but personalized to tailor to help you and your symptoms that will work for you, certainly.
Fantastic. I think that's great advice. Well, thank you so much to all of our speakers for another fantastic session. And we are now going to go into a break and hear from Body Braid. So I'm going to hand over to you now. Thank you.